So as Darius said, I'm going to be talking about innovation in informatics. And while I'm going to be speaking from my experience going through an informatics training program, a lot of these concepts are actually not specific to informatics. And I'll call out where some of those informatics specific things are. But where this stemmed from was I get a lot of emails and people coming up to me asking about how my experience was. I actually have a meeting tomorrow morning with somebody at CHOP as well as next week of people who either have ideas that they are trying to think of what are the next steps to take or just trying to get an overall gestalt of what the experience was like. Because I think there aren't that many people who go through this process from start to finish. And with that being said, this is not a randomized control study. I didn't survey a ton of people to present the data that I'm presenting today. You could think of this more as a case study with an N of 1 being me and kind of what my experiences was and obviously take that for what it is. So I have a disclosure, as Darius said, I am a stockholder and employee of Phrase Health, which is a healthcare governance and analytics company. And by the end of this talk, I'm going to be covering a lot of topics, but some of the main learning objectives that I'd like you to be able to come away with is really getting a sense of how one could potentially navigate the academic innovation environment. 2, there are going to be several potential failure points along the way, and I'm going to try and call those out specifically so that you can kind of identify those if you find yourself going through a similar process. And then finally, I think in order to really start growing and accelerating an idea, funding is obviously very important. So how we were able to identify different areas of alternative funding rather than more traditional grant-funded research. So a little bit of background to put everything into context. It's not like I came into the fellowship and out of the blue I was really interested in software development and learned then. I've actually been doing software development since I was in middle school, was taking AP computer science software courses in high school. I recognize that this picture is actually not of me, and I make a joke a lot that I'm not a pediatrician, although in emergency medicine we do get exposure to pediatric patients. And I'm fairly confident that is not a middle school aged child in that picture. But I'll probably need a pediatric consult for that. So I also, when I went to college, I wasn't focused exclusively on engineering and computer science. I actually explored an economics degree, and I was really interested in this idea of efficiency and optimization, and this also drew me to the idea of entrepreneurship and how you could really make change where different problems existed by using your limited resources to really try and optimize some steady state there. So as an example, straight out of my undergraduate career, I actually was managing several volunteers at the emergency department at UCLA, and this was very early informatics work. We were doing time series analysis of the workflows within the emergency department. And this was well before the age of electronic health record systems, so it involved actually manually observing when patients were going in and out of the rooms for different things, and really were able to boil down where some of those workflow bottlenecks were to be able to optimize those processes. And then additionally, kind of on top of that, I then took a job also at UCLA, working in a neuroimaging lab where I was writing scripts to measure structures in the brain based on MRI imaging for addiction patients who are coming in as part of this study. So that lays some of the groundwork for my background. And I'm going to start the story of how I kind of went through this journey from academia to a startup by starting it in medical school. And when I went to medical school, a lot of inefficiencies that existed in the system. And one example of a project that I tried piloting when I was on my ED rotation was that there were a lot of inefficiencies in how students were getting scheduled, how they were getting feedback back to the directors and so on. So I had built a really quick prototype, showed it to the course director, which she thought was really great. And we kind of trialed it very, very briefly, and then I had to move on to my next rotation, which was really busy, and this kind of just fizzled out and didn't go anywhere. Similarly, when I kind of graduated and went on to residency, there was a very clear problem where patients who were in their patient rooms were sitting and just waiting hours and hours on end, just being able to watch TV, but not really getting any feedback around how their care plan was going. And that wasn't because the providers didn't want to tell them. It was because we were so busy running around to high acuity patients or managing and juggling a lot of things that were going on that we just didn't necessarily have the time. And I thought this would be a really great opportunity to just put a simple tablet computer within the patient rooms, pull very basic information around who is your care team and what are the high level things that you're waiting on. So I started talking to the IS team, and this was my first foray into the complexity of healthcare standards with HL7 and so on, which was very off-putting at first, but I ended up also applying for a grant to try to get some infrastructure in place to get tablet computers. And this was an uphill battle all the way, and again, eventually started fizzling out as the demands in residency kind of took place. So as I was putting together this lecture, I started thinking about general trends that I was seeing. I would start a project, I had an idea, let's kind of go in and just create some MVP, some prototype, then go out and seek support. Let's try and talk to some people around, is this valuable? Is this going to be helpful? And then ultimately it would lose momentum. And kind of when I was putting these slides together, I started putting a lot of thought into why had this kind of happened repeatedly. It's not like these ideas were particularly bad. And in fact, Epic is now making a big push to having tablet computers in patient rooms to kind of give them some of that insight. So the idea wasn't bad, but why did this stop at a certain point? And as I was thinking about it, I think an idea clearly is important. I honestly, my opinion is that the idea doesn't even need to be that great. And I have a lot of ideas, Daria could attest to that. I'm sure all of you have really great ideas of how you can identify a problem and say, wouldn't it be great if we kind of made this change, whether it's technical or not technical or whatever. But that's not enough at all. And kind of my hypothesis around some of the key core pillars that I've experienced going through this journey are really needing time. So you need to have time to be able to explore these opportunities. And obviously, when you're employed by somebody else, that time should really be part of your job responsibilities, unless you're wanting to spend time outside of your work responsibilities and doing this on the side, which obviously is just going to be a much bigger burden on you in your personal life. Having mentorship, having people who are able to support you and walk you through and guide you through next steps, and when you are hitting those failure points, being able to help pick you up and kind of come up with new ideas. And then finally, institutional infrastructure. So being able to access, whether it's data, connected to data systems that you might not have otherwise have access to, or having access to tablet computers, or some of these other things. And this even qualifies as CHOP has an amazing research infrastructure. So being able to plug into people who can advise you on applying for different funding types and so on. So I'll be hitting on some of these themes as I go through to kind of let you know in my experience how I was able to kind of navigate this at CHOP, and I'm sure at many other organizations it's going to be a similar thing. So I was really fortunate and honestly lucky that in the last year of my residency, this new kind of concept of a clinical informatics fellowship came to be. And this was the original white paper that was published in 2009, where it really outlaid what is clinical informatics, what clinicians with that expertise should be able to know and be able to do. And as such, I actually started really exploring clinical informatics. So I spent my last year of residency really learning about what it is. So per that white paper that I just showed, they define clinical informaticians are ones that transform healthcare by analyzing, designing, implementing, and evaluating information and communication systems that enhance individual and population health outcomes, improve patient care, and strengthen the clinician-patient relationship. Sounds great. I was like, I'm sold. But I need to explore, actually, how does one apply? And this is actually the email. I found the old email that I wrote to Tony Luberti the first time that I reached out to him. And I started doing a deep dive into what does a fellowship entail. Found out that it's a 2-year endeavor that you have to pursue. I, for personal reasons, wanted to stay in the Philadelphia area, and CHOP still maintains to be the only program in the Philadelphia region that has a fellowship. But this was a really big unknown, not just to me, I'm sure to Tony as well. I mean, we were embarking on something where there wasn't a good track record of how graduates were coming through, what types of jobs they were getting, what was the training going to be most efficient for. But I thought it was going to be a really great opportunity for me, so I applied, and luckily, in retrospect, I think this is one of the best experiences that I've ever had. So I, like Darius said, I was one of the inaugural ACGME fellows at CHOP. And kind of going back to those pillars, I think what this did is it gave me dedicated time to really explore things that were directly of interest to me. I was able to identify, I think now CHOP has over 20 board certified informaticians, a lot of faculty, and a lot of other innovators who might not be specifically informatics, but can speak very cogently around things that I had been kind of struggling with. And then additionally, CHOP has an amazing institutional infrastructure, again, around supporting research, being able to provide some resources here and there to be able to test certain ideas out. And my personal focus was really on interoperability. Coming as a software developer, I still thought it was insane that I couldn't access data from an electronic health record system in the same way that I could connect with Facebook or Twitter or all these other systems that hold tons of data that can be very kind of sensitive, but still have protocols in place. So I really kind of spent a lot of time trying to learn about that process. And then finally, the fellowship afforded me the opportunity to gain certifications in working with the EHR, whether it was analytics, build, Chronicles programming, which is actually kind of going into the belly of Epic and actually building your own APIs and so on. So this was an amazing experience. So along those lines, I want to give a big thumbs up. Anyone who has any questions about the fellowship, please reach out to Tony Luberti. I think he's one of the pioneers in informatics education. And I know if you're even a medical student and are starting to think about this, especially residents and even attendings who kind of want to go back and kind of get this more formal training. So the fellowship opportunity also afforded me to be able to present at a variety of conferences. This is actually a slide that we presented at Epic XGM, which is their expert user group meeting. And it was based on Fireworks. So Fireworks was the inaugural kind of hackathon that Epic hosted, and this was, I think, the first or second year of my fellowship. And it was an amazing opportunity to go out to Epic, network with their engineers to be able to ask them specific questions, as well as work with people within our informatics department. So I got to go out there with Jarrett Thayer, who's one of the programmers, and really kind of make a cohesive team and identify where areas that we could be improving as an informatics group. And what I point out here is the project that we did in our inaugural attendance at Fireworks was addressing antibiotic stewardship to a certain extent by when the clinician places an order for an antibiotic, it goes into Epic's system, into their data repository. It would send out an API request to our server, and then we would go back to Epic and request all the old culture sensitivities for the antibiotics for that patient. And if the order for the antibiotic that the clinician had ordered in any way conflicted with resistant cultures in the past, we would actually trigger an alert at that point and say, are you sure this patient has shown previous resistance to this antibiotic? And I thought this was a really cool problem where we had this solution that could address my work in the emergency department, because oftentimes I don't have time to go through all the lists of old culture results, especially for complex patients, and identify all the different sensitivities they've had, but to have the system kind of automate that recommendation for us. So this is really where the beginning of Phrase comes. So I was in the fellowship. I think, as I mentioned before, the fellowship afforded a lot of time, and I was able to work with Bob Grunmeyer as part of our mandated clinical decision support rotation and really fine-tune what we were doing in decision support around these interoperability questions and problems that I had. So what happened is there was a Health 2.0 closing the DBHi challenge that Naveen and I had recognized, and there was a prize, I think, for $50,000 maybe. And the challenge that they had put out to the public was, let's try to bridge the gap between the public health group and frontline clinicians. So we submitted it and we won, and that was great, and that started getting us traction. And then a few months later, we applied to the Department of Health and Human Services FHIR challenge, where we kind of made some adjustments and made this FHIR base. And then we were a phase 1 winner and an honorable mention in the finals for that. And this really kind of put us on the map at CHOP and started getting the attention of some people at CHOP. And this is where I'm going to have these little potential failure points at the bottom to kind of delineate where I identified in this journey problems where you could have a great idea and some traction, but your project may fail because of these reasons. So I approached one of the research departments at CHOP, and this is not at all meant to be a knock against them. I just think innovation and formal research need to be two separate buckets. And when I approached them about potentially helping and getting involved in this project, they gave me this big pack of papers, and they were like, can you fill out all of the research aims and kind of your methodologies and all of this? And that was just not going to be consistent with how rapidly we were adjusting and changing. So that was going to be a big problem to work with any of the established research groups at CHOP. I think something else that we often got feedback about was, this really isn't novel. This isn't kind of the newest idea here. People have trialed this before. And I will make the case that when there are competitors in the field, or if an idea isn't novel, that doesn't mean that they're doing the best. If anything, it means that there is validated group of people in a market that is interested in that space. So that was something we kind of heard intermittently. And then finally, anytime you're working on an interoperable project, being able to be interoperable at your one site is not kind of that big of a feat. Really what you want to do is start kind of moving it outside of the organization and testing some of those concepts externally. But when you run into other organizations, unless your value proposition is so high, they have a lot of other things that they're doing. And at this early stage, it can be extraordinarily difficult to convince an external pilot site to test out your software. So this gets back to, for those who were lucky enough to attend Daria and Flora's lecture, I think it was a couple of months ago as part of this lecture series, they talked about the Valley of Death, and this really resonated a lot with me when they presented this. And the question is, we're getting external validation. We won some of these contests. Really at this point, it's just me moving forward, because Naveen, who was my co-fellow at the time, had started really transitioning more towards an academic career. So I could see that there was going to be this drop-off of how am I going to continue to get resources to help me do my work and have this not be a one-man shop, even though we've kind of started showing these proofs of concept that are being validated. And at this point, I had an idea. I had time as part of the fellowship where I was working on things that were aligned with the goals of the fellowship. I had started kind of connecting with different mentors. I think the main thing that was lacking at this point was infrastructure at the institutional level. How do I navigate that? How do I identify kind of who are the people to talk to, and so on? And luckily, OEI came into play, and I see some familiar faces from OEI here. And I think the year that we started winning these awards was actually the first year that the sprint program came into play. And what the sprint program is, and I know that they've, OEI has talked about their program, and I think this is their most recent email about their sprint program. But this is through the Office of Tech Transfer, and really trying to identify interesting IP and ideas, and then providing that infrastructural or institutional infrastructure. So I was able to I was accepted into the program, which obviously was amazing, and I was assigned essentially a project manager who is helping me, not just with some of the idea validation, but I think one of the greatest values that they provided was helping navigate the bureaucracy that can be a large academic system, identifying who are the people we need to talk to open up these doors, to allow us to kind of proceed to the next test. I think, honestly, I put stars next to these because these are super important, and was one of the biggest lessons I learned from going through the sprint process, is that we needed to talk to potential users. And this is something where you kind of need to go outside of your comfort zone. We were really lucky that OEI funded us to go on a roadshow where we talked to, I think, 10 plus different people, kind of showed them the technology that we had developed, asked them about their feedback around kind of what are struggles that they're having, what are their processes, and this was extraordinarily important. And then from that feedback, then iterating really quickly on testable concepts and ideas and running it by potential users. And I want to make a point that this is really not just applicable to academic projects. This is applicable to projects of any kind, whether you're a startup or a big company that has a little project in it. Taking this approach will minimize the amount of money that you'll spend overall. And hopefully, if the project's going to fail, you'll fail a lot faster and waste less time on it. So, based on all that feedback, we decided to pivot. And this is where we go from PHRASE, as capital PHRASE, which was an acronym for Public Health Risk Assessment Support Engine, to PHRASE, which was kind of our newest iteration that was no longer kind of part of that process. So I actually remember distinctly when we came back from this roadshow and kind of hit the books again, we had a meeting with some of the leadership at CHOP, and we presented some of these ideas, and it kind of fell flat with the group, because I think as an organization whose motto is breakthroughs every day, I think they're looking for kind of those like cures for cancer and these things that are going to really revolutionize in one swoop how change of care is delivered. And I think what the lesson that we really learned is that while the technology that we had developed was really cool, interoperability in informatics is kind of the most important thing of all. So if you try to implement solutions at other organizations, but standards don't exist, your ability to kind of get in the door and really kind of disseminate some of your ideas is going to be extremely limited, because these organizations need to dedicate a lot of time and resources to basically customize your solution on their end. So we ended up pivoting at this point, and I think in retrospect this was a great move on our part, and I'll kind of talk a little bit actually to what our solution has become from that public health alerting system where we had been working with the CDC and the local public health department to this other solution. And just starting at a very fundamental level, for those who might not have a lot of experience with this, clinical decision support is really patient-specific knowledge that's provided to the end user in order to promote better care. And based on some research that Ken Kawamoto's group had done, the keys for success are to have it be integrated into the clinical workflow, that it provides some recommendation and not just some information, that it be presented at the time of the decision-making process and not downstream or upstream from it, and ideally being computerized in some fashion. And as far as examples, a lot of people will think of clinical decision support as just alerts, but that is not the case. Order sets are very effective means for decision support, and I kind of use the example when I'm in the emergency department. We have an order set that I use for stroke patients coming in, and there's maybe 7 or 8 orders, I just need to type stroke. A big set of orders will come up. A bunch of the really required orders are already pre-checked. So it saves me a lot of time, and I'm selecting the orders that have been curated by the experts in the stroke division. So that is kind of compared to a situation where I may just be trying to remember one-off orders at a time, is going to lead to a lot more variation and potentially the patient not getting the optimal care. Note templates, kind of the same deal. If in my note template in the ER, I have an EKG part of the template, and it serves me as a reminder that, oh, this patient does need an EKG, and I might have forgotten to get that, or they might have forgotten to get that in the triage. And then reference info, CHOP, Penn, many other organizations use UpToDate, which is one example of reference info. One of the problems there most of the time is you need to know that you don't know something, where a lot of these other pieces of decision support really apply to the situation where you don't know what you don't know. So with that being said, I'm going to put into context a clinical situation that you guys should all be very familiar with. This is the patient clinician interaction. I'm going to use a surrogate as a treatment, as a medication here, but oftentimes a patient will come with some complaint. The clinician will provide some medicine to try to address that complaint. And then it's very normal and accepted to evaluate and monitor, did that medication make the patient better? Did the medication make the patient actually more sick from the side effects? Is the medication not helping? This kind of loop of evaluation and monitoring is very, very accepted and normal. But that entire interaction is more complex than that. As the physician is putting their orders within the electronic order set and getting the data around their vital signs, their past medical history, and so on, there are other interventions that are being served to the clinician. And these, again, can be alerts that pop up and say this patient had a stroke, they should be placed on a statin, for example. Or maybe that patient is allergic to that statin, so an alert will pop up and says, are you sure you want to order the statin medication for them? So here's an entire other area of interventions that are taking place geared towards the clinician. The problem that we learned as we went on this roadshow and started reviewing a lot of the literature around it is that this evaluation and monitoring and management is very, very poorly done and is very, very difficult to do across healthcare systems. And the evidence behind this, I'll kind of just talk about a couple of pieces. This is work that Adam Wright and his team did up at Partners a few years ago, where they evaluated all the different types of ways that decision support can malfunction. Here's an example of a lead screening alert that for 2 years basically stopped firing. So clearly no one was doing any monitoring of this. No one was actually ensuring if this alert was achieving the aims that it needed to be, because it wasn't kind of effective or active for over 2 years. And he outlines other ways in which decision support will malfunction. Obviously, if it starts firing a lot more than usual, you'll typically get your feedback from your clinicians that something is seriously wrong. But for situations like this, you need some kind of monitoring system in place to do that. And then more recently, this is just within the past couple of months, that same group at Partners published a paper around what they call cranky comments. And what this is within the electronic health record system, there's actually a way of providing feedback when you override an order, for example. So they started looking at all of the feedback that was being given, and they were able to ultimately identify that about 26% of their CDS was malfunctioning based on this feedback. And were able to kind of use this to make changes to their system and actually improve the process. So I think there's good evidence that these processes aren't in place at many organizations, as are outlined in this research, but also from going on these road shows and talking to different organizations. There are very few organizations that do this, and this is kind of scary because this is potentially going to lead to a lot of downstream problems. And the challenge that really exists for these informatics teams is that they're really responsible with limited resources to use the EHR to deliver safe and quality care to patients, but without overburdening providers. So on one hand, if we really ramp up the number of interventions we're going to put into the system, we're going to lead to physician burnout, and they're going to ignore the alerts anyways because they just need to get to their task. Where if we kind of go all the way in the other direction and say we're going to limit the number of interventions we're going to have, then again, we're back at square one, where we're not really providing them with the support that they need, and they're not going to kind of, they have the potential to not do the requested action or really the optimal care delivery. And really, where is the optimal level is where we've spent a lot of our time now with the software that we developed starting in the fellowship and now have spun out. And ultimately, with this information, we are able to pull out the log data. We present it in a dashboard for the informatics teams to use, and not just use, but manage. So assign metadata around when it's being reviewed, who are the stakeholders who are responsible for this in case it breaks, being able to tag and bundle different types of CDS together, and really just give them a much lower threshold for being able to handle a large, complex CDS library. And then finally, once you identify some insights from there, we're able to work with the clinicians who are being burdened with these alerts and try to identify other workflows and just taking the alerts out altogether, or doing some test of change to try to improve the alert and then reevaluating whether we're getting better response rates from it. So that's kind of how we pivoted and where we started focusing our efforts. And when I was working with OEI, the Office for Entrepreneurship and Innovation, I remember being told that there are really a few buckets that some of these ideas can go into. And kind of one very traditional bucket is that this can be a grant-funded research project. Oftentimes you'll need to look for external, again, oftentimes from the government, grant funding. And that was really not a great fit for us because there was nothing there were no grants that were available that were really addressing the problems that we were trying to solve, at least in the way that we envisioned wanting to solve them. It can be an internal operational tool. This is something that CHOP has explored with their Telederm application, and oftentimes you'll need to identify internal funding, but that's going to be a tool that's going to help operationally with the functioning of the system and ultimately patients within the system. Another option is licensing the technology. So we were able to start doing a little bit of this early on with other academic centers, but I know the Tech Transfer Office works really hard to try and find IP and then find external partners who may be willing to pay for that IP and continue to fund it. But you need to be able to find those external partners, and that's a lot of burden on the Tech Transfer Office. And then finally, is this potentially a new company? And you need a new external partner, so some new company that's going to form, and oftentimes is that going to be you as kind of the main inventor and the driver and the person who's really passionate about it, or are you going to identify kind of another set of people who are going to take the reins and push it forward? And I would argue that those companies are going to struggle on day one because they don't have that passionate person driving it. So then getting to funding, I think when people think of industry and startups, they think of like fancy cars and all this money that you're able to get, but in reality, I think this is more of the situation that we face. And when we talk about non-traditional funding, I think there are a few different areas, and I think some organizations are luckier than others in what types of fundings might be available internally, but I'll also be talking about some external opportunities. So I think it was really great that my fellowship program was through the informatics department, so I was able to identify really kind of big champions and advocates for the project who were able to, when I was done with the fellowship, continue to fund my work and continue to fund me as a research scientist. OEI was a great opportunity. As we started growing and getting traction, we identified that I can't do this alone. I need some help, especially on the engineering side, to help shore up some of our platform as we were starting to deploy this to other organizations. So I think OEI is a potential group there. Like I mentioned, contests and challenges. I mean, we're not talking millions of dollars typically, but I think we ended up total bringing in $50,000 to $70,000 from some of these challenges, and that's enough to definitely push you to the next level to start helping get contractors to help you do some of that work. And then finally, as was mentioned before, licensing the technology was something that tech transfer was extremely helpful in. I basically was able to identify potential academic institutions that might be interested in this, and then tech transfer was able to take the next steps to say, all right, we'll work with that organization to come up with some licensing agreement and able to get some revenue from that for us to continue to fund our project. Another potential failure point that is definitely worth calling out is if you are even thinking of spinning out at some point, or even not, but you're trying to build a team internally to help support you, I think it's very difficult within academia, and academia is not really kind of well built for doing this, and the biggest reason that I identify is that there's no equity to offer a potential engineer. So one, you're limited in your resources that you have available as far as money is concerned. So you have to spend a lot of effort. I was going to regular meetings at least once a week to Penn and Drexel events that they were hosting, kind of just trying to meet people, network. And it takes a lot of effort to identify people who are willing to work for basically below market rates, not have equity that they're assigned to, and really just trying to get them to be passionate about the project or the program. And oftentimes I was asking people to volunteer some of their time, which again can be really difficult. And one topic that came up a lot that was recommended to me was looking for interns. And I think interns are really great, and as somebody who's been through medical training and wanting to train the next generation of people who are interested in these topics, I have to say they're really, really tough to work with, because in informatics, the learning curve to getting people up to speed on kind of what you're working on, what the data entails, there's a big commitment of time, especially when you have a small team. And then the next thing you know, their summer's over, they're working on another project now, and you've kind of lost them. So I would definitely be very hesitant very early on bringing on interns if there's a big learning curve to your project. And then seeking support. So as I started getting more progress and traction working with OEI, I was able to connect with folks like DBHi, more about this, who had spun out his Haystack Informatics company, as well as Flora Winston, who had been involved in her diagnostic driving company, which had spun out. And these are great mentors to have if you have interest in kind of different paths you're potentially thinking about, to talk to you about what are the risks, these are the stumbling blocks, but ultimately trying to push you along and nudge you along if this really is a passion of yours. So I want to show, I think, what we think of as the commensurate innovator, this video.
No, I've actually always found something to be very true, which is most people don't get those experiences because they've never asked. I've never found anybody that didn't want to help me if I asked them for help. I always call them up. I called up, this will date me, but I called up Bill Hewlett when I was 12 years old. And he lived in Palo Alto. His number was still in the phone book. And he answered the phone himself. Yes, hi, I'm Steve Jobs. I'm 12 years old. I'm a student in high school, and I want to build a frequency counter. And I was wondering if you had any spare parts I could have. And he laughed, and he gave me the spare parts to build this frequency counter, and he gave me a job that summer in Hewlett Packard, working on the assembly line, putting nuts and bolts together on frequency counters. He got me a job in a place to build them. And I was in heaven. And I've never found scream about it. You gotta act, and you've got to be willing to fail. You've got to be willing to crash and burn. You know, with people on the phone, with starting a company, with whatever. If you're afraid of failing, you won't get very far.
So, I mean, I think that's a really poignant kind of message, and definitely resonates with a lot of some of the stuff that we had been working on, and really pushing yourselves to talk to people, to get their feedback, to talk to them, to see if they're willing to help you. And again, as I pointed out before, I think OEI did an amazing job of really kind of pushing us into that outside of the comfort zone to get feedback from these people, as well as kind of seeing if they're interested in helping support your work. Really quickly, I'll talk about research and how that led to some of the opportunities that we had embarked on. So there is a very close connection between exploration of your idea and research. And this is in the upper right corner. This is a maturity model that I've been working with Naveen and Evan Ornstein, some of our previous fellows, as well as Daria Farrow. Based on all of these discussions that we had with organizations, we started distilling all these different themes down. And we've now shared this with multiple CDS groups across the country, and they find this very valuable to kind of give them a sense of where they are in their progress towards really moving towards a mature CDS group. So this is work that even now that I'm outside of academia, still involved in research and still involved in trying to disseminate best practices. Been able to give presentations at the AMIA Symposium. I'm going to the CIC conference in Atlanta, where I'll be on a panel with other clinical decision support leaders talking about the maturity model and how organizations are trying to advance in their CDS. And these presentations are great for networking, for getting feedback, and so on. And one thing of note, and this may or may not apply to some folks here who might have connections with small business or thinking about going down this path, but the government does have an TTR and an SBIR grant program, which are grant opportunities that are exclusively for small businesses. But as an example, again, I'm working with Naveen and Evan down in Emory to put forward a grant proposal to really kind of push our platform to the next level. So there are opportunities if you're interested in working with startups, or if you're planning on doing a startup yourself, to going back and getting involved in that. And I think I had mentioned to OEI and Kelsey Pagden about the NSF. They have their I-Core program, which I think is another great opportunity for people within academia. I was not aware of that until kind of I was getting towards the end of the track, but they really push you to do that customer exploration. I mean, one of the main goals of that program is go out, talk to people, identify where the problems are and where the potential solutions are. And one thing to always keep in mind when you're doing research with academic institutions is how the IP is going to be split up and negotiated. And then my final slide around my experience goes to negotiating with tech transfer at the end. And this was a big enigma to me. I had very few mentors who were able to kind of describe what this process was going to be like. While you're employed, almost all academic systems, or almost all employers, maybe not even just academic, if you're using any of their resources, data, systems, or while you're on the job and you develop some IP, that all belongs to your employer. Oftentimes, and I know this is the case at CHOP, you have the rights to any revenue that comes in as far as licensing and so on. So that's why I would highly encourage anyone who has an idea, whether it's super early or you've started going and getting traction and so on, to really engage with the tech transfer office and disclosing that IP, and then working with them to try to identify if there's areas you could get revenue from them to continue your research, essentially. And then really briefly about the spin out. It's totally an open negotiation. So there's no policy in place, there's no rubric. Obviously, I think a project like ours, which was relatively small compared to some multi-million-dollar CHOP-funded project or grant-funded from the government, is going to be a very different experience. But despite my very kind of limited exposure as far as funding was concerned, relatively, it still is a very long process. I mean, this took on the order of 4 months, 6 months, maybe even longer. So just so you're aware, it's not something like you just snap your fingers and the policy kicks into place and you've spun out and that's it. And one quote that I got from one of my mentors, which was a little jarring, is that you go from being on the same side of the table where you're working collaboratively on everything, and then all of a sudden you're sitting on the opposite sides, and then you're kind of negotiating and really disagreeing around a lot of stuff. And you're able to come out of this with good relationships. It's not like it's a miserable experience, but it's definitely a change in how you are interacting with your colleagues. So in conclusion, there are kind of several different things that I think contribute to being able to successfully navigate this, and ideally trying to find positions where you're given time that aligns with your interests and your innovations. Working at a place that is able to provide institutional infrastructure, and ideally finding mentors. Some of the failure points that I pointed out were being able to identify support, so whether that's kind of somebody who can volunteer their time, or folks like the project manager at OEI, and securing some kind of funding to help you grow. Those are all potential failure points. And then I discussed some of the alternative sources of funding, like those contests and challenges, internal operational stakeholders that might derive value from the projects that you're working on, and potentially licensing externally these technologies. And then my final slide is just, I think startups are really glamorized a lot. I mean, there's Silicon Valley on HBO, and it makes it fun and cool, and I think a lot of the success stories get glamorized. But it's really, really hard work. I find it very rewarding, but it's really, really hard. And I think this can be catalyzed by working within departments and organizations that really are interested in supporting it and have potential resources or expertise. And it's really important to seek out those that have paved the path. So Flora, like I mentioned, in BML, were really helpful in kind of guiding me a little bit. And the final point that I'll leave with is you really need to be dedicated and to really try and persevere, because there are a lot of these failure points that pop up, but those shouldn't be thought of as your project is a failure and isn't going to work, but really this is how we can make it stronger, so we can pivot and change based on some failure that we've achieved, and it's a new lesson we've learned. And projects can definitely lose momentum if the inventor isn't committed. I'm sure that's something OEI has to deal with at times. And I truly believe that if there is a problem that exists, that initial idea might not be the solution, but you'll eventually pivot and find the solution, just in the same way that many other successful companies have started off with one idea and are completely separate businesses. And the last video, I'll show you a short video from our kind of commensurate innovator.
People say you have to have a lot of passion for what you're doing, and it's totally true. And the reason is because it's so hard that if you don't, any rational person would give up. It's really hard, and you have to do it over a sustained period of time. So if you don't love it, if you're not having fun doing it, if you don't really love it, you're going to give up. And that's what happens to most people, actually. If you really look at the ones that ended up, being successful, unquote, in the eyes of society, and the ones that didn't, oftentimes it's ones that were successful loved what they did so they could persevere when it got really tough. And the ones that didn't love it quit, because they're sane, right? Who would want to put up with this stuff if you don't love it? So it's a lot of hard work, and it's a lot of worrying
hopefully that didn't scare anyone off. But I want to acknowledge basically the entire phrase team who's been helping me. Obviously a lot of people at CHOP who have been so integral to the work that we've done, from the Office of Entrepreneurship and Innovation, as well as DBHi, and this clearly doesn't kind of complete the entire list of people at DBHi who have really helped. And then finally, the pilot sites. Like I mentioned, it's really hard to convince pilot sites to give you that chance, but we were able to kind of go live with Temple and Penn and really prove out the concept and prove the value. So I don't think we have that much time, but maybe if there are quick questions.